Good morning, everybody. I'm going to talk about the management of the perioperative anticoagulation today, which leads me to the topics that we're going to talk about. We're going to go through these agendas. When is it actually safe to perform surgery without increasing the risk of hemorrhage or thromboembolism? Which leads me to the cascade of the blood coagulation. I guess every one of us has tried to memorize the blood coagulation cascade during the medical school, and it is a complicated system. So I thought we maybe go through the important part of the coagulation cascade in a short video as a memory hook.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor VII. Finally leading to the activation of factor X. This factor Xa is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor X. Since the two pathways merge at the level of factor Xa, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor Xa in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor Xa can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor Xa in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Which basically leads me to the question for the residents. Do you know any possible targets for the anticoagulation in the blood coagulation cascade?
Well, first you can antagonize the coagulation synthesis of the factors like vitamin K, for example, or direct antagonists of the factors like we saw before of factor X or 2, thrombin.
Absolutely correct. So the possible targets in the coagulation cascades are mainly the coagulation factor synthesis themselves. To this group belongs the vitamin K antagonists and also the factor Xa inhibition. Like the low molecular weight heparin, danaparin, fondaparin, nux, rivaroxaban, apixaban, and also edoxaban, and unfractionated heparin. And we do have the factor 2A, which is the thrombin himself inhibition through the dabigatran, bivarubidine, igatroban, and also unfractionated heparin. The effects on the antithrombin dependency can happen in a direct or an indirect way. We do have those both groups. The directly inhibition the effects on the antithrombin dependency can happen through the rivaroxaban, apixaban, edoxaban, dabigatran, and the indirect way, as you can see, through the danaparin and fondaparin nux, and also through the heparins. The administration way can be in an oral way and in a parenteral way. There is also a classification in the anticoagulants groups. And we do have also the way of monitoring them. Typically, we do monitor the vitamin K antagonists, the unfractionated heparin, bivalirubidine, and argatroban. And occasionally, we can also monitor rivaroxaban, apixaban, edoxaban, dabigatran, and the rest of the listed substances here. And there is also the way to separate them in groups that we have specific antidotes for them. we do have currently antidotes, specific antidotes for vitamin K antagonists, unfractionated heparin, low molecular weight heparin, and dabigatran. And there are also specific antidotes. They're not available, or they are not available yet for the rivaroxaban, apixaban, edoxaban, and also for the porodoparinux and the rest of the listed substances here. And there is also the matter of the half-life of this medication. We do have medication, basically substances with a short half-times, something about 30 minutes up to 3 hours. And we do have some of them that they have intermediate half-life, like rivaroxaban, apixaban, edoxaban, and dabigatran, something about 4 up to 10 hours. And there are some of them that they have a long half-life, like danaparid or fondaparinux, with over 10 hours. And we do have also the antiplatelet drugs. These substances can be separated into groups who inhibit the COX-1 enzyme in an irreversible way, as is aspirin. And we have the ADP receptor inhibitors like clopidogrel and prasugrel and the rest of the listed substances, and also the glycoprotein 2B and 3A antagonists like apiximab and tirofiban. This substance, the most important substances for the anticoagulation has been listed here. As we can see, they have a really different level of the half-lives. For example, the fenprocoman has a half-life something about 80 up to 240 hours. And the pre-last one, valirudin, has a half-life something about 30 minutes, which is really low. And there is also the matter of the accumulation of these substances by renal insufficiency. Some of them, they do not accumulate. Some of them, they have a really high liver and accumulation, as you can see by dabigatran. And there's also the matter of the specific antidotes. We do have, for example, for those 4 underlying substances, which belongs to the direct oral anticoagulation, we do have specific antidotes like andexanet. And basically, because of the limited time, I will be focusing on the DOACs, of the direct oral anticoagulations. And the direct oral anticoagulation can be separated in 2 groups: the direct oral thrombin, which is the factor 2A antagonists, and also the direct oral factor 10A antagonists. We know the dabigatran as a Pradaxa, and also rivaroxaban as Xarelto, there's a commercial name, and also apixaban as Eliquis, and edoxaban and Lixiana. They have been made basically phase 3 clinical trials for the important indication for those medications. We do have basically approval for venothromboembolism prophylaxis after orthopedic surgeries for dabigatran, rivaroxaban, and apixaban and edoxaban in those listed trials, and also for embolism prophylaxis by atrial defibrillation and acute treatment and secondary prophylaxis of venothromboembolism. And there are also other clinical trials that are still undergoing for other indications. For example, the secondary prophylaxis after acute coronary events for rivaroxaban. That's the ATHLETS trials. And there is no approval yet for this indication. For the thromboembolism, thromboprophylaxis by acutely ill medical patient for rivaroxaban, they found out in the McLean study basically that there is a higher bleeding rates, and so no approval for this indication. There are no trials and no approval in the general surgery for this indication. And also about the mechanical heart valve prosthesis for dabigatran, there is a higher embolism and bleeding rates than the vitamin K antagonists, which is which is a contraindication for this one. Next one. So basically, the current approval in Switzerland for the DOACs are for the venothromboembolism prophylaxis only in the orthopedic surgery or general in orthopedics procedures for rivaroxaban and apixaban. For venothromboembolism, there is for rivaroxaban, apixaban, edoxaban, and also for dabigatran. Well, I have to say that in the cases of edoxaban and dabigatran, they started basically to giving the patient the edoxaban and dabigatran after initial parenteral anticoagulation over 5 days. And also for atrial fibrillation, there is a current approval for rivaroxaban, apixaban, and edoxaban. There are no approval for venothromboembolism prophylaxis in general surgery, cardiac valve prosthesis, pregnancy, or patient who are undergoing a lactation period. So there are practical aspects about the DOACs, the perioperative time interval, the antagonizing by bleeding, and especially also in emergency interventions, and the way of monitoring them. The surgical intervention, so basically in the most intervention, a suspension over 20 hours is enough for this group of medication. It means that the patient has to take his last medication something about 2 days before the operation. In the case of the high-risk operation, like in the central nervous system or general surgery, they recommend to suspend the medication over 48 hours before the operation. It is the matter of the longer leading time by kidney insufficiency, especially in case of dabigatran, which accumulates really high by kidney insufficiency. So there is not recommended to take this medication for patients with kidney insufficiency, or we have to stop or suspend the medication over 96 hours before the operation. There are definitely lower bleeding risk for the smaller intervention like in the dentistry or skin biopsy, and there is no suspension needed. And if there is any further testing needed to check the antifactor 10 activity, we have options with antifactor 10A tests or thrombin time. So I have also to say that the perioperative bleeding risk have not been investigated systematically in this matter. There is a, for example, in the case of the rivaroxaban, we can see they recommend to stop basically the medication, to suspend the medication at least 24 hours before the surgery. They can start to take the medication 1 day after the surgery, which is a risky thing. There are experts who think that we have to stop almost 2-3 days before we start the medication to take a rivaroxaban post-operatively, or if there is necessarily, we can start bridging with heparin. There is definitely the problem with the bleeding if we start with the anticoagulation really shortly after the operation. So as you can see in this case, we can have a higher bleeding risk, for example, in this case, after a kidney transplant. There's the neutralization of the DOACs. We do have specific antidotes. Dabigatran has a specific antidote, which is idarucizumab, and the factor 10A antagonists like andexanet. The short half-time of the DOACs is really beneficial. So basically, after a short time, the concentration of the substances in the blood going to be so low that the effects are going to be also lower than the rest of the medication, which have a really higher half-life time. And there is also the possibility to take dialysis. Dabigatran, we can do an initial dialysis, and there is also the matter of redistribution. We can distribute with a volume of 60 up to 70 liters. For rivaroxaban and apixaban, they are really highly bounded proteins, so the dialysis is not really promising in those substances. So what we do in the case of the bleeding, there is the question, what medication did take the patient, with what dosage, and what was the indication? And of course, the question, when was the last time that the patient took the medication? The peak serum, as I said, is almost arrived at about 2 up to 4 hours after the medication, and the rapid reduction, because of the really short half-time, is beneficial for us. And there's also the matter of the monitoring of the peak serum with antifactor 10A and also antifactor 2A test or thrombin time. If you have a slight bleeding, so there are symptomatic measures to take, for example, local measures or application of tranexamide acids, or in general, the postponing the next dose of the medication. Or we do have substantial bleeding. Of course, discontinuing the medication is recommended, and emergency matters, and also hospital admission if there is a if they also taken patients. The antidotes for these DOACs basically are the prothrombin complex concentrate. We know that as a Beriplex or Prothromblex, and also there is a recombinant factor 7A, which is Novo7, and the specific antidote, as I said that before, for dabigatran, which is idarucimab, and factor 10A antagonist, which is the inactive factor 10 molecule. As we can see in those graph, on your left-handed side, they are basically sampling the blood of the patient over 24 hours and testing the thrombin time. Patient with undergoing a procedure by basically on the left-handed side, the patient taking idarucimab by bleeding, and on your right-handed side, our patients who are undergoing an emergency intervention. And as we can see, basically the level of the thrombin time is in the group who are under idarucimab is lower in general in the first 24 hours than in the group without taking these antidotes. And there is a peak after 4 hours, about 100 seconds of the thrombin time in the group without taking these antidotes. And here, basically, on the left-handed side, there is apixaban. On the right-handed side is rivaroxaban. Here is also they have been given the specific antidote, antifactor 10 antidote, which is andexanet. In the graph A, they basically gave the andexanet as a bolus, and in the C, they gave it as a bolus and as an infusion. And they compared the patient taking these antidotes with the placebo group. And on the right-handed side, there is the same procedure via rivaroxaban. And as we can see, basically the antifactor 10 activity is with the bolus in general for the first 2 hours lower than in the placebo group. And if we add an infusion with the specific antifactor 10A, we have a longer time with a really low antifactor 10 activity up to 4 or 5 hours. We have an algorithm at the University Hospital in the ER, which has been established in the last years. If we do have a patient in the ER who is taking anticoagulants and we do not know which medication is it, so we do have the possibility to check the quick and ENR and the thrombin time and the antifactor 10 activity. And if you go through these basically lab tests, there is the vitamin K antagonist. They have an influence of ENR, which is going to be higher. If the patient only have a thrombin time, the thrombin time is higher. So basically, he might have taken dabigatran, and if only the antifactor 10A, and sometimes ENR is higher. So basically, he's been taking the factor 10A antagonists. This is a really short review about the anticoagulants and their indication, about the cerebral thrombosis and lung embolism for heparin and pentasaccharides, and also about the atrial fibrillation and prosthetic heart valves. There is no indication for fondaparinux in that case. And for the vitamin K antagonists, for the atrial fibrillation and the prosthetic heart valves, there is still the therapy of first choice. But we can also give the patients vitamin K antagonists in the matter of cerebral thrombosis or lung embolism. And about the oral factor 10 inhibitors and thrombin inhibitors, are indications for approval for the indication such as cerebral thromboembolism and lung embolism and atrial fibrillation, but there are no approval for prosthetic heart valves for those groups. So when it's safe to perform surgery without increasing the risk of hemorrhage or thromboembolism? The answer to this question is really complicated because there are a lot of factors that have influences in this matter. So the American College of Chest Physicians proposed guidelines, especially in the 8th and the 9th edition, about the antithrombic prophylaxis in patients with different risk factors. So thank you for your attention.
Well, thank you very much. I enjoyed the movie very much. What we understand is that it's very complicated. There's a lot of drugs associated with that. So I must say that I tried to follow everything. I could not follow all this medication, when to use it, when not to use it, etc. And one factor is the economy based on that. I mean, the cost of this is sometimes very expensive. Maybe if you want to make a comment, or if you know what are the costs associated with this, so the economic aspect of this. And the other question, very simple question here, you did not speak much about aspirin.
That's true.
So, and that's what we have most common. Many people take aspirin, low-dose aspirin now. Sometimes they say, sometimes they don't say. Should we completely ignore that for all surgery? What should we do in this situation? I mean, typically we have to stop a week before or 5 days before, maybe tell us. And the two most common, I think I use is aspirin and clopidogrel, that we can see, and maybe just simple recommendation for these two anticoagulants that are widely used in the population, and people who don't have specifically risk, at least for aspirin.
Yes, absolutely. So, for example, I know that from the cardiac surgery that it depends on the indication that the patient's taking those medications. They're taking aspirin, for example, but they stop taking clopidogrel several days before, and we try to bridge that with low molecular weight heparin or with heparin himself if the patient are at the hospital. But I guess it is mostly depends on the surgery. If there's a higher risk of bleeding, so we can stop clopidogrel for sure, but the aspirin is, I guess, in every clinic is different how they're handling this.
As a rule, in patients with a high cardiovascular risk, we would not usually stop aspirin. We would continue aspirin. And whether or not we stop clopidogrel or another ATP receptor antagonist depends on the risk. So the latency from stenting, for example, whether it's within 3 months, 3 to 6, above 6, or above 12 months since the stent was placed. And there is an algorithm which was published by the anesthesia, which is available in the intranet, to give an orientation on dual platelet antagonists.
Another question, in some major surgery or liver transplant, we have tried to have this patient may bleed, and we use routinely when in high risk the citalopram, the antithrombolytic agent, antithrombin agent. What's the risk associated with thrombosis in these cases?
I would consider the risk as being very low. We would not usually give it in cases of hematuria in order to prevent clotting. We would not usually give it in disseminated intravascular coagulation, and we would not usually give it when there is external circulation. But otherwise, I would think the risk of thrombosis triggered by these antifibrinolytics is very low.
One question is, you know, if I compare this to chemotherapy, we see now much more drugs for anticoagulation. So it's like we had 15 years before only one drug. Now we have plenty. Is there any web tool where, you know, a patient comes into the emergency room, you enter, let's say, you know, the numbers, quick and platelets, and then you ask for risk, medications, and then the tool would basically come up with choice number 1, 2, 3, 4. Because I could imagine in 10 years we have 20 efficient drugs. This is one question, and the other one is, goes this similar way? Gobi, is there anything in this area where you also go to a more personalized approach? That means, you know, what we do for cancer, that we know some patients perhaps respond better to this drug compared to the other one?
It is a developing field. There is no such algorithm, but of course we take several factors in account. For example, renal insufficiency, liver insufficiency, whether it is a patient with an active tumor or not, and the like. So for example, active malignancy, first choice would be low molecular heparin regarding to available studies. And now as the first and so far only one of the direct anticoagulants, edoxaban, Lixiana, for which very recently non-inferiority has been shown compared with low molecular heparin. Studies are ongoing for the other DOACs. I would expect all of them to be available for malignancy. We tailor which anticoagulation we use for certain patients, of course. But there is, as far as I know, no such algorithm. So it is sort of a personalized medicine, which we apply, of course. Or dabigatran, we would not like to use it in a patient with renal insufficiency because it accumulates, and most of bleeding complications or even deadly bleeding complications have occurred because this has not been taken into account.
Thank you very much for the detailed presentation. I have a question on my own. We see a good number of patients now who come to surgery with one of the newer anticoagulants, rivaroxaban, Xarelto, or Eliquis. And the question always comes up, how many days before surgery do we need to stop these medications, and what do we need to measure? When do we need to bridge with heparin or low molecular weight heparins? Is there an algorithm? Is there an easy rule for us to follow?
It is quite simple, because the standard case is that you would not have to bridge preoperatively. In patients without a very high risk of bleeding or with substantial renal insufficiency, you would give the last dose at day -2, so with a distance of more than 24 hours. In selected cases, I would give or consider preoperative low molecular weight heparin at a prophylactic dose, for example, the evening before the operation, but the standard case is that you would not need a preoperative bridging. For patients with an atrial fibrillation, you would not need a bridging at all. So this applies only for venous thromboembolism.
Just have a short comment, because you were showing a patient with a kidney transplant, just to let you know that patients on the waiting list for liver kidneys in Zurich are not allowed to be on direct oral anticoagulants because of emergency planned operations. So they have to be on Marcumab.
So thank you so much.